they are much similar that we are using, maybe much more refined and with a better methodology. So this is where everything is started. And Sushruti is a lot of medicine for us, a lot of surgery actually for us. Okay. Coming back to the recent years or recent trends, is Carlos Cortelelli. He was from Argentina. And till that time, before 1948, everything which was there was all done from posterior. It was all posterior midlines that we started. So in 1948, we had the largest series at that time, how to approach from posterolateral part into the vertebra. And we did more than 1,000 biopsies under X-ray control. And he is credited to start the posterolateral approach. We are what we are doing as of today. So he gave the foundations of the future transforaminal approaches. From Carlos, it was imbibed by Craig. I think everyone knows the name of a Craig. And whatever vertical biopsies, even translated biopsies that we are doing is through this Craig needle sometimes. Something is different version. But Craig gave the needle. And if you see today's entry point for the posterolateral, the entry point what he gave was around 6.5 centimeters from the midline. Then he went and then we went inside this space and aspirated and did the biopsies. So that was in 1956. Coming from there, we all know about the same approach which was done by Craig, was extrapolated by Smith from USA, and we did a time of the pain or chemonucleolysis. And chemonucleolysis was the first minimally invasive procedure for this. That's what I would say as of today. Use the same entry point body transformer approach that we are having. Around 8 centimeters, not 6.5, around 8 centimeters lateral to go exactly inside of the disc. So that is the next stage which came. From there on, 63 came the era of Dr. Burns Henry. And at that time in 1973, he used the wider cannulas, but he did a percutaneous discectomy in addition to an open surgery. So it was not endoscopic surgery at that time in 1975. It was an open surgery, then he put in the cannula, and then it is indeed the discectomy. So that's how it started in 1975. He was a professor from Jackson University, US. Parallel to that, because there was no internet, nothing was there at that particular time. So you just think it over that one person is working in USA, and at the same time, another person was working in Japan, and that was Professor Nishikata. And he presented in 1978 about the percutaneous material. So both were independently working. But he used 2.5 cannula, the cannula used their larger diameter by Dr. Kennedy. So that's in 1975 to 1978 era. Taking from that forwards, it was taken from Sikot, and then from Japan Sikot, it came to actually Switzerland, where Switzerland in 1979, we were practicing the opening in Europe. So he pioneered this work. And the work describes a safe working zone in the introvertible foramen. And that was his first anatomic study of the lumbar nerve for percutaneous discectomy. And that he did it in 1979, even before the name given by Dr. Kennedy. So as of today, what we are talking about Dr. Kennedy, although it was more complex because of that, but he was the first person to exactly anatomically define that this is how the anatomy of the root is there, and That's the Cambridge triangle. So that then he started developing along with other Swiss surgeons on the same principles. Austrian Frost and Frost in 1983. They are having first nucleoscope and used what they did was they did an open dissection and then put a nucleoscope there to find out whether they have done a complete job or not. And this is what we are also doing as of today, that if you see some surgeons, they are doing a discectomy from transcranial and then putting a scope to check whether complete clearance of the disc is done. So it was the same concept in 1983 that we wanted that whether this clearance was done completely or not. So that's how, and that's from the same article that I've taken all this. And you see, there was no video monitoring. You can see that was a scope, and this is an extension so that you can look in like this. So that's the picture of that. So that was in 1983. Coming from there, Faber, in 1984, that was the first worldwide publication on lumbar disc. And he used actually dual force, and you know why the dual force were used. Because there was no working channel endoscope. So they had to put a scope from one side and from the other side as a working channel, another scope was put, and then they started doing the dissection. So it was first dual port arthroscopic nuclear column done by Faber from Switzerland. Then came the era in 1985. It was Shepherd. He did not clear the disc very well, but he entered the disc and put the goggles inside, thinking that putting a hole inside the disc space without complete clearance, you will get the piece. That's from his article that he started putting the hole inside. There was no instrumentation at that time. He did not have the idea that we need to clear up the end plates to get a better fusion. So it was just a bone goggle, which was taken from Clover. They were putting a bone goggle, then used the bone goggles for putting inside this piece. Of course, it failed, but still he tried that. So you know that how it has evolved. Then came the era of Cambridge. I think he extensively studied all these things, and then he popularized that how everything needs to be done. And that is in 1988. The first thing that he did was not a fusion. The first thing everyone knows that he did was an arthroscopic microdissection. And he defined all the things which were not matching with the previous nucleoscopes. He built the articulated instruments and specialized instruments which are required, and did a discectomy and lateral assisting also. That was in 1988. He defined and gave the name as the Cambridge triangle. And that was also during that era that he actually defined the borders of the Cambridge triangle. Now we know it is a prism rather than a triangle, but still he is the pioneer for that. The first attempted fusion or percutaneous endoscopic interbody fusion with pellicular screw with an external fixator, which was actually designed by Nagel from BIU, that they used this external fixator, and then he is credited for being the endoscopic interbody fusion with pellicular external fixator. So he did the bicortical endoscopy, then he put the external fixator, and then he removed the external fixator after 3 months. So till that time, 3 months, the patient had to be on the external fixator. So that's how it has evolved. And then that was their first paper, but a complete technical evaluation and a good number of series were given in 1996. And it's very nicely described in University clinics of North America, where they had a bipolar technique. They developed a very good instrumentation, and the instrumentation, this is what is the cutter which they developed to clear the end plates. They develop this type of cutters, and you can see that using the cutter, put the external fixator, remove the external fixator, and you can see that there is a very nice fusion which was seen in all under local anesthesia at that time. Of course, the schools were not, but the other things were all under local anesthesia. You can believe that. So the things that we are having, that we are doing all the things is black part. That you should not, you should be narrowed down enough that we are not the first ones to do all this. From 1996 to 2010, I just jumped because everyone knows about this history. That first year schools were given by Dr. Foley and Anthony Young, Newton, and they three actually revolutionized the endoscopic transforaminal approaches till 2010. And then we got a very good instrumentation at that time. The first trans-scanning fusion report was in 2010 by Rolf Morgenstern. They put the particular screws, they did a foraminoplasty, and then they put this type of cage, which is a normal cage that we have, and that they reported in 2010. So it is Rolf Morgenstern that he did a first case report. In 2012, it was Sai Ikman who did a case series of this procedure. But yet he said that it has a limited triangle. It was 60 patients report in 2012. That is a limited triangular space, low level of enthusiasm, this approach because of technology. There was no technology to clear all this. So instruments were there. So he did it, but he had some restrictions. And then this paper came in 2013, whether transforaminal lumbar interbody fusion is worth it, whether you should do it or not. But the discussion was there of that there are 57 patients and 11 patients had, and you can see 22.8% patients had a rate migration. That was the rate in 2013. So given a 36% competition rate this series, they did not recommend it unless device technical improvements are made. That was the recommendation in this paper. And this was the first time again, the insertion of a self-expandable, what we are talking about is expandable cage. That was first reported in 2015 again by Morgenstern and Rolf. But having said all these things, I think it is Professor Abbas in 2015 came up with his first paper. If I am wrong, just let me know. This was his first paper. And this is what the design that he did. This is what we are going to follow again today also. This is the case design. This is how the entry points are. And he had a 69 patients follow-up in 2015. So he standardized, popularized standard method of how to do and he also coined the term over the line. Till that time, nobody coined the term over the line. And he also, for the first time, did it without an endoscopy. So everything changed from 2015 that you can do this procedure without the use of an endoscope. Till that time, even modern students were using the endoscope to do this procedure. And then in 2022, that was the first case report with an expanded application, which you can see now in last this SSAT. So many companies have come with the expanded application. That was in 2022. I think I will stop here. I don't want to go with my evolution. The world evolution is much better. Thank you.
For the second to talk. Next, I would like to invite our board director, Dr. Hamid Abdullah, who is a board certified leading group who has traveled all the way from Minnesota, US. He is an internationally recognized expert in minimally invasive spine surgery and is one of the most experienced surgeons that perform the OLIF procedure. He will be going some light upon the pre-operative preparations and how implant design matters in whether
Thank you very much. Well, first of all, thank you so much for all of you being here. And I have prepared a fantastic presentation, spent a lot of time on that. But looking at you, interested people, young people, energetic people, I'm going to discontinue this presentation and just talk to you. I mean, I have like 120 slides. I'm not going to show you any of them except one. And the reason for that is I think looking at you, and thank you, Varun, my dear friend. What you have put together is truly amazing. I think I wanted to tell you a story rather than give you yet another boring medical thing, bunch of numbers and so on. All those numbers you can get and read by your own. But the story behind that, I think, especially for younger people, or you know it in and out, and most of the doctors here know it in and out. But I want you to tell you a story. And the story starts in 1998, when my chair in Germany, Dr. Peter Schmidt, who was a very renowned vascular neurosurgeon in Germany, called me in his office and he told me that he cannot continue employing me. He told me I'm too unconventional. And in that setting, in the University of Heidelberg, he could not give me a residency anymore. As you understand, I was devastated. I thought my neurosurgery career came to an end. And but after I called myself, I started studying for USMLE. And my lesson was being unconventional was all my life. I didn't start starting my residency in Heidelberg. I did a PhD in computer science. And for younger people here, I apologize, Varun. I'm going to just talk 10 minutes and give you a different story than you expected for me to give here. Always get out of your way, do things that you think are relevant to your field of study. Have a broad education. Don't concentrate on, I was in med school, but my PhD was in computer science. That helped me initially completely understand neuronavigation. If you're familiar with that, these are machines that the two cameras in the OR, they transfer CT and MRI into the room that you see the tip of the instrument in the patient's brain. All of a sudden, we went from opening this big in the skull, opening this big, and the patient started doing so much better. I understood those machines because I went out of my way at application in computer science. So when I started looking for another job, I found a job in Stanford, California. For some reason, they needed my expertise there. And I went as a researcher there, and my job was day in, day out, plugging them the computer in their OR. And at that time, these days, computer OR medicine is very intertwined, but at that time it wasn't. But I could go to those rooms, set up those machines, connect them, and would understand them. So the disaster one that was, I didn't have a residency, I couldn't be a nurse anymore, opened up a new avenue. I was all of a sudden in one of the highest institutions, and I worked on a surgical navigation system for spine. Because my thesis, my computer PhD was we took their actual scans of the hip, we sliced them, and then we created a virtual reality model of the hip, and then we could cut in different angles, and then see how that different angle of cutting really they result in better or worse surgery for the hip, actually. Now, I just can tell you the machine that we used for that, we bought it for $750,000. We bought a graphic card for $240,000. That graphic card had 512 kilobytes of memory. And we could do 5 million polygons, create this model of the computer. computer and then work with it. Lo and behold, you guys have no idea how lucky you are. Because probably your Apple Watch does 10 times stronger than the machine I work with. In 2000, in Stanford, we wrote similar programs to use navigation and calligraphy and changed the entire computer industry from calligraphy. So be go educate yourself, go learn anything that you can learn. The story then goes that I did another 6 years neurosurgery residency, but I did 13 years neurosurgery residency. I did a lot of schooling. I was trained under probably 170 attendings. This is not usual. Again, I have been told I'm a conventional person. What that means is that by training under so many people, and I'm seeing here all medical students, residents, and so on. This is truly advice I can give you. Find the surgeon or doctor who treat the most complex cases. And the way you can do that, find the person who has a lot of complication. Some of them they just have a lot of complication, but some of them have a lot of complication they take care of because they take care of very complex cases. Because that is the right time to learn all of this. So by training by so many people, I had a really good background about anatomy, about how things work in the OR and what works and what doesn't. So when I was done in 2008, by the way, I got done in 2008. I was a junior attending, and hurricane came, destroyed the entire city where my university was, the hospital, and so on. And literally had to move. There was no university, there was no town. So I had to find a new place, and I started practicing. And again, me being unconventional, all the doctors around me started sending me the cases they did not want. And you will notice that eventually, medicine wears you down. You just want to have a good life. What that means, you want to take care of healthy patients. And I have no idea why anybody would become a doctor if they don't want to take care of truly sick patients. So, whereas for the other doctors, older doctors, they just saw it as dumping addition on me. I saw it as, oh my God, this is a difficult situation. How can I treat it? How can I help the patient? And that pushed me always forward and forward. Again, being unconventional has hurt me a lot, but that has helped me. So I finished my residency in 2008 and started practicing, and I started seeing a lot of complex cases. I can tell you, medicine and surgery is about doing difficult cases and getting good at it. And then in 2012, somebody told me, and I considered myself a good surgeon, but in 2012, somebody told me they know of a new procedure, and that new procedure is called OLLIA, and I started looking for literature, I couldn't find nothing. I talked to that representative of the device company, I said, excuse my French, I said, bullshit. Nobody does that surgery now. But my blessing was I didn't say bullshit and I just walked away. I said, bullshit, I want to see it. So, even though general visit, but I did take time. I went to Atlanta, Georgia, and I wanted Dr. Calvin. Certainly, other people have done variation of this, but the three doctors that really consolidated that, they were Dr. William Kelly, Dr. Bishop and Dr. Jerry Schoen that put literally, we call it MacGyver kind of. MacGyver is a TV show in US where this guy just takes some random things and build the airplane and so on. So they MacGyver different tools and things to go to fusion because endoscopy, yes, it was already there. As a matter of fact, I talked to Dr. Kambi 9 months before he died and described to me how he came to do this surgery. He literally went with a urologic friend, took the urologist's straight scope, put it in that space and noticed that there is actually a space that you can work with. So I watched Dr. Kali do the surgery, and what with the cage you saw there is the cage Dr. Kali used, and the system he used was more refined but still very rudimentary. And that surgery was like flying space shuttle. It's doable, but only few people can do that. But my eyes were open that there's another way of doing it. And I came home and I worked many years, and we published a paper in 2015, but I was doing it from 2012. I put everything together, made the surgery easy so other people can do it. And this slide, the only slide I want to show you because this really summarizes what the consequence of the surgery is. And I can just tell you about the United States that at this point, less than 2% of the spinal fusion in the lumbar spine are done in a surgery center. And there's a reason because they are considered very invasive surgeries. You can, in the United States, you do this surgery, you keep the patient many days in the hospital, they have high rate of infection, it's a very painful surgery, the patient takes 6 months, sometimes longer. It's not India. The Americans are very pain sensitive and so on, and it takes them a long time to go back to work. And there are about 40% of the people who know they have a pathology, but they are too sick, they are too old, they are too big, they are not in a situation to get the spinal fusion. Now, I chose this slide to show you what this is about because you will see in the next few meetings and the next few talks about the procedure, how it's done. And I will show you probably the next day or two, literally, physically, the hardware. You will hopefully see the actual surgery tomorrow. But in medicine, advances happen in increment of 10, 15%. Advances rarely happen in 100, 150, 200, 300%. But all of a sudden, we have changed the entire landscape of spinal fusion. Now, there are other ways of fusion that they still have their own validity. But now we have another tool that all of a sudden, a 7-hour surgery becomes a 1-hour surgery. The 1 meter of blood loss, 1,000 cc of blood loss become literally a 25, 30 cc of blood loss. The risk of infection goes from 5 to 8% to 0.3%. Patient that would stay in the ICU 2 nights, all of a sudden in 2 hours after surgery can go on. So, in the bottom, this future, what you see here, is for me reality. I do 3-level fusion in my surgery center. Instead of patient home within hours. So I can take care of lots of patients in the surgical center setting, and a lot of patients who didn't have that choice, now all of a sudden can have the surgery. We can change people's lives. Especially when we get old. If you're still in the United States, elderly is considered 75 years old and older. If you are 75 years old and older, if you stop walking for whatever reason, your prognosis is poorer than if you have. You can keep these people ambulating, you give them literally their life back, and you can do it day in and day out. And I want to tell you that it's a combination of technology and training. What I did in the last 13 years, I made a very complex process an easy process. When you come and see me and Dr. Sharma was with us, things just happen, and all of a sudden surgery is done, and 2 hours later, the patient go home. They have a smile, they go home, and they literally are able to, within a week or two, go back after multiple surgery to regain their lives. It's a combination of technology and training. You have a beautiful fighter jet, but you cannot fly it, it's useless to you. And that is where it comes from. To learn that, you need to have a good amount of basic information. And what I see in India is a lot of skills. I've never seen so many skillful surgeons in my life, and I have trained a lot of people. I was in Chennai, and after the third surgery, the resident, they just cut it. I'm not used to that. So you're very lucky in a place that there's so much skill exists. Now, let's talk a little about the actual technology, the device. You saw the anatomy. The Lord, however you want to call him, gave us, throw us a bone, that's what he said. They gave us a path, he gave us a path. The path is though not very big. I just want to show you maybe one more slide to for you to understand what I mean by that. So, if I move away, can you still hear me?
Yes.
If I move away, or do you have a? Thank you. Okay, but you still hear me.
Laser pointer.
Or maybe laser pointer. You have me over that as well. Give me a second, then I can stay here. Just use the laser pointer. So. That path to get the surgery done is that white line right there. But the idea is here that we can, with the right tools, right training, we can use that little white line here to go to a place that is void of nerves and void of vessels. That's all what it is. Now, come to the technical part, how to do that. You need something that respects the nerves around that area. You need something that enters it easily. For the first 4 years when I was doing that, I was just refining just the instrument together because you remember the thinking that they MacGyver it, meaning just put something together that worked, but wasn't too specific. Now, with the proper tool, we could do the surgery much better. Then in 2016, we start redesigning the cage. The cage is the part that goes inside of the disc. So the cage you saw, there was a plastic cage in my paper. It's a piece made of kind of plastic. It has a very concave nose, so open up the space. Notice sometimes it's hard to get it in. So we designed that the tip of the cage is concave, meaning that I can call it arrow. But an arrow is supposed to penetrate easily. Then we noticed that if you make the top of the cage a little more like convex, you have more contact to the bone. And that helps you to have a better contact to the bone and the end plates. And then a few hundred years later, those teeth, we call it on top that has connection to the end plate, they cannot be too sharp. They have to be like a wave rather than like a jigsaw, like a saw and so on. And then notice a few hundred years later that if you put windows on the side of the bone and the vessel can roll there. So, and little by little, over 13 years and 2,027 cases, that is where we are now. We now do that surgery through that very small, narrow path for a vulnerable fusion, usually in half an hour. And Dr. Sharma was with the actual placing of the cage, which is usually takes 1.5 hours. It takes for us about 10 minutes. 8 to 10 minutes, we are done placing the cage. And then we can repeat that, and that all of that is what allows us to literally do 3-level fusion in a surgery center and send the patient home within a few hours. Now, for some people here, maybe that is sending the patient home same day is not a big deal. Okay, what's the difference and so on and so forth. I just need to tell you, the United States, our first paper was not a technical paper. Our first paper was an economic paper. Because medicine, you make innovation and you double the cost of everything. What we found, because of shorter hospital stay and the same cost of the hardware and tremendously lower risk of infection, if you would convert even a fraction of the surgeries to this, you would save $3 billion annually in the United States. $3 billion. Now imagine how much you could do with $3 billion if you reduce the cost of the surgery. So this is one of the things that the technology actually reduces the cost of taking care of the patient. And I try to literally bring this technology to the rest of the world. And in the United States, unfortunately, there are lots of Spain is big money. For the rest of the world similar, but when there is a big money, there is a big interest. Okay, like companies like Medtronic or other big companies, they have just $1.5 billion inventory. They have no interest to change the landscape. But I didn't quit, I'm just a very stubborn person. I continue doing that. And then I noticed outside of the US, people are more interested in this. And I presented it to the rest of the world. And here, that's why I'm here, because you guys are smart. You know opportunities when you see it. And you are not bound by economical things that brain that is said. By the way, that we can even describe this. Nobody followed that in the United States. We went to China, South Korea, then India. Let me tell you, we in the United States are re-importing endoscopy from you guys. And many of my friends have come here to learn endoscopy. So we're proud of who you are and what you are doing, okay? So, but production was extremely expensive in the United States. And I'm really proud here that I'm able here to be here, give this intellectual property free to my friends and you, so you can take it to the next step. So I'm going to stop here, but I know you will catch me along this next 1.5 days. We will have more conversation about what we are going to do, but this is the message. You will hear a lot of technical details. But the message you take from this, if you are young, if you're a medicine, if you're a resident, should be this. Don't do other things as well. Don't get too concentrated on one thing. Don't be afraid of complication or things that are not usual. Don't walk away from something that is not mainstream. Sometimes they're nothing, sometimes they're chasing rules, but sometimes that's what differentiates you against the others. And as well, don't lose any opportunity to learn. Okay? Well, thank you very much. I appreciate it.
Thank you for that enlightening talk. Next, I would like to invite Dr. Amit Zahar sir again to discuss about his experience with IF and how he does it.
I guess I prefer an anatomical nomenclature. Something that by just the name you understand what it is and what it's about. Now, And there are a series of approaches to Cambrian triangle. And all of that supposed to take you to that triangular or prismal thing that enables you to use that bone that the Lord gave us to get there. Now, there's few important structures, but the most important one is actually the nerve in that location, which we had a picture of. You need to preserve and respect that nerve. If you, and there are three ways of doing that. Dr. Jala and Dr. My good friend Dr. Mazavada, they use an endoscope. They look at that area, they make sure where they're entering the disc, there is no nerve. And that version is called PALEF. The fully endoscopic version of the surgery is called PALEF. And as a matter of fact, that was the first thing that came on. The people then later on decided not to use endoscope. Then how else can we respect the nerve? We can use neuromonitoring. If you're not familiar with it, you put electrodes in the leg, and then you put a monocular electrode that you measure how far you are from the nerve root. And we measured that, and we did studies. We found out if you have no electrical activity of the nerve root, the insulated electrode up to 4 milliamp, you are within more than 5 millimeters away from the nerve root. So, additionally, if you get double Sion, you know always the exact location of your instrument. So, and practically, in the so-called PALEF, you put the endoscope at the entry of the Cambrian triangle. You see you are not damaging the nerve by going through. And in the OLLIF or oblique lateral posterior lower interval diffusion, you literally only rely on X-rays and neuromonitoring. Now, for those who are not familiar, we are doing PLIF since 1950s, TLIF since 1980s, and these two are in the United States still are 80% of the surgeries performed with these two methods. Now, these are anterior approaches, they are very good approaches, but I want you to understand and not confuse this OLF with this OLF. This is oblique lateral interval diffusion anterior to psoas, meaning anterior to this muscle right here. So you go in that path here, the disc, and they're oblique, both of them, but this one is transcambium OLF, whereas this one obviously is not transcambium. And hopefully that makes sense. Now, let's talk about how to get there. Now, I'm not going to talk about the selection algorithm, but practically, this is very efficient surgery. But if your primary goal is to cut the bone and open up the space, this is not the right thing. The primary goal for some surgery is, in some situation, is to change the anatomy of bending of the spine. This is not the best procedure. So, what I want to tell you is that this is all what we need to do the surgery. And these are already produced, available for everybody. And I want to actually go through them individually and explain how I do the surgery, and then watch a 5-minute film. Okay? First of all, again, all you need is here. And you didn't have everybody took a picture of it. This is a normal probe. It is insulated all the way to the tip, and there's a sleeve over it. You get connected to your machine, and you can literally see how far you are from the nerve. Once you're in the right place, there's a metal sleeve there. The metal sleeve is shorter, so they don't shunt. Once you're in the right place, this goes down, the probe goes out, and this K-wire or Krishna wire goes in. Then you have a path from inside of this end, the outside of this end. So a dilator goes in, then over the dilator, a working cannula gets hammered in, And then we have a series of tools to get the disk space out. And this is what I did in the last 12 years. Refine those that they do a job, one job only, but they do so well their job, and you don't need a 5 set of instruments to do perform it. And then at the end, you package the logic and you put the cage in, you see the stage. This is the version 4 cage, and if I blow it up, you will see that it's biconcave in the tip, biconvex at the end plate. And that's it. Actually, these are other things that you don't need for this surgery. And so this is what you need. Now, I'm going to show you the animation. Then we are going to look at some x-rays. And hopefully that won't take long. So I'm going to just, this is the field in the wall. And I'm not going to talk about the setup because that we will see later. Now, I want you to see that this is all you need. The front table, the back table, and that's for critical instrumentation. Now, for people to understand that in a regular surgery, you have like 4 or 5 of these tables, sometimes double deckers, to have all the instrumentation. So it's a very simplified procedure. Now, let me go to the animation here. Let's watch this animation here. So, you want to remember the anatomy of the triangle? This is the ganglion that you're afraid of, that we have to respect. Now, here you see one cell going back and forth. It took me a lot of cases, but I only did the double cell because it's significant at your efficiency. You see, we mark the midline, the APN lateral, and we draw it. After 2,000 cases, I still draw them on the patient. The idea is going at 45 degrees and aiming for the, not for the canting triangle freehand, because after 250 cases I learned, if you aim for the pinnacle of the level below and then drop it in, you are more efficient and you can pass it with the first rather than the 3rd or 4th pass. Why is it important? Because if you pass more than 3 times below the transverse process, the rate of nerve irritation actually doubles. Here you see that probe talked about. And you see here you are too close, but then you can reposition it. This is what I do. I touch here to drop down. And if I'm here at 4 million, I'm more than 5 millimeter away. Then you see here, K-wire is inserted, the dilator goes in. And here you see that over the dilator, the portal access goes in. And we hammer it in. Then a series of tools go in. This is, you see the drill here, which create a space inside of this. Literally, I take those chunks out. And this is another instrument. And these are very specific to this, and it goes in, it opens up. And literally remove the cartilage and the material from the end place. As you see here, sometimes you see a tool, you have no idea. Let me tell you, probably 15 engineers worked 3 years to refine that. Just one tool. It's a lot of work to make something like that happen. And here you see another tool, the grain current that comes out, goes 20 millimeters up and down, and opens up and remove the material. And then here we are packing it with biologic. And we're talking about this biologic that I'm using from calcium phosphate in a collagen matrix, but we sold it to bone marrow 3 to 5 minutes. Now, here you see that P cage, the plastic cage. I'm not using it anymore because of what we discussed. You see in each of those cages 2 metal ends, so you can, in the X-ray, see the position of the cage, but plastic itself is not visible. So now I'm going to show you X-rays of the same procedure. And they're taking very few minutes to do that. Here, let's start with this. Okay, here we go. By the way, everything you see here is on YouTube. I have hundreds and hundreds of YouTube videos that you can watch. But more importantly, I have over 1,000 patient testimonials. Literally, I take time in my visit clinic and ask the patient, what's your story? How did you do? How was it? Let me just tell you, more than 90% of them tell you that when they woke up, the leg pain was gone. What that means that by restoring the height of the disc, you could get rid of the symptom of the pressure on the nerve, right, without your provocation. So here you see a seismic spondylolisthesis. I'm just going to move forward a little here. So we see the actual surgery. Beginning of the surgery is orienting the films and regard to patient. It's very algorithmic. I can just tell you, and that's one of the things I told Dr. Sharma, and I don't see anybody else who has visited my thing, that if you come and watch me doing a one-level fusion in 35 minutes and you walk away and say, Abbas is a great surgeon, you wasted your time. You literally didn't get the message that I'm trying to convey. The message is not Abbas is a good surgeon, the message is you follow those steps, anybody, any spine surgeon can do that. That is the message. And so the films are so that when you look at the patient, you are looking at the film. Jamshidi needle goes in, I get my bone marrow that I mix with my biologic. While my biologic is soaking in the bone marrow, I start using the so-called probe. I'm stimulating at 3 million of them. I go to the top, I fall in, then the K-wire goes in, dilator goes in. As you see, lifting up the bone, we can put the dilator under the cage, right, left, front, back, and you see the air gets sucked in. When I do that, air gets sucked in. Now, a series of tools will go in to remove material here. Now, what you need to know, the nerve root is protected by two, meaning that whereas in regular surgery, I go 50 times back and forth with the sharp tool. Here, I go only with dilator once, and then literally all the action happens inside of the tube. Now, you see the cage is in place. Now, what you need to see that this foramen is much bigger. Now, I'm spending a little more to put screws here, K-wires and screws, and this is the final result. What you don't see very well, but is down here, right here, is that from the beginning to the end of the surgery, we spend 25 minutes. This is, and I need you to understand, you're not rushing the surgery. You're not cutting corners. Like, he just came from Mumbai here to Bareilly, and how long would it take Dr. Sharma if you would be driving from Mumbai here? How long would that take? 12 hours. Now, imagine you're in a landscape you don't know flying, and I come and tell you, he came here from Mumbai in 2 hours. What you think is Abbas is crazy or Abbas is lying if you don't know the concept of flying. But if you know the concept of flying, that you don't have to go through all those streets, you don't have to cut the skin, you don't have to cut the muscle, stop the bleeding, then move forward, you don't have to cut the bone, you don't have to do all of those things. All of a sudden, it makes sense. You're not cutting corners. Because for the first 6 years, whenever I went and said you can do surgery in under an hour, they couldn't wrap their head around it because they didn't know you can fly. Okay? So there are a lot of animation online. Please look at them. The variation, there are many variations. You say in America, there's a lot of way to skin the cat. I have no idea why they use that. I'm sure it's, I hope it's not coming from actual skinning the cat. But what that means is that you can use different ways of getting access. And this is the way Yeah, I have protocolized, I have made it algorithmic, and so that if you repeat those steps, you will have the same results. And I can tell you how many of this you have to do to have this result versus that result. Now, tomorrow, hopefully, you will see me doing one of these procedures. And I'm really happy that I can help the patient. But what I'm really proud of is that the people who follow the algorithmic approach to this, within 10 cases, have as much experience that I gained at the 200. People are doing now, people are taught, they are doing these complex cases after 70 days, like scoliosis, Graves' spondylolisthesis, where it took me 700-800 cases to do. I'm proud of that, that I can pass the knowledge and people get better than me, faster than me. Okay? So, your question will talk more later. But I'm sure we will talk more about the procedure evaluation of the system. Thank you.
Question. So you use both monoclonal or bipolar monitor?
This is a monitor probe. The other now, any monitoring, any probe, any electricity is always bipolar. Just a question about where the two poles are. So for practical purpose, this is a monitor because the other pole is down in the legs. I put electricity and I see it close to the nerve. The other pole is the muscle that starts stimulating. The electricity passes through this probe and a neutral probe somewhere in the skin. But the idea is if that it's too close to the nerve, that amount of the electricity energy that's there causes action potential in the nerve root that literally then you can measure the activity of the muscle. Now, what you need to understand is not like leg is moving. The actions are minute, but the machines are able to measure them.
Yeah.
The monocular for practical purpose of your question.
Yes, I am a neurosurgeon only, so we use a monocular probe only. And my question is, what current you use, sir?
But
What current, what milliamp you use?
very good question. Now we are really technical. We have published actually multiple papers about this. Do you have additional neurosurgeon here? Just okay. Wow. Thank you. Okay. Well, let's talk about headlet core. We had this conversation yesterday, and one of our orthopedic colleagues, I give you credit, you don't work with the nurse that closely, so it's okay. It's okay not to know that. But when we do headlet core, you open up this dura, and then these lines are going down. Headlet core is when we grow up, when we are a baby, our spinal cord fills our entire spinal canal. But when we grow, the bone grows faster than the nerves, so meaning that our spinal cord retracts. Now, some unlucky people use a small little band. That little band keeps the outer spinal still, and that color can stretch and stretch and stretch. When you open it up, sometimes you have to go cut that band in pump division. When you open it up, that band and the nerves not always easily recognizable. You stimulate them, you put electricity on that. Now, to see if it's a bone, I'm sorry, if it's a nerve or is it just a band? Because if the nerve, you don't want to cut it. If the band, you cut it and close it, everything is great. So, who wants to tell me what amount of current in milliamp you need when you do a tethered cord? Where you go to a nerve that is a it looks like a peripheral nerve because it's called a spinal, but you don't have dura around it. I want to say, just throw a number out. What milliamp amount of energy do you use?
We usually use a 0.01 or 0.5.
Perfect. You see, for a peripheral nerve without the dura, 0.1 to 0.5 is what you use to identify if it's a nerve or it's a band, and then cut it and you're done. Now, the nerve from here is not a it has a dura around it. And now, let's say I get this probe, I put it on the nerve root itself, directly on the nerve root itself. So maybe somebody else, you're well versed in that. Maybe one of my Persian friends. What about if you take a probe, put it on the nerve root directly, how much electricity you have to put on that to put an action potential? There's something, whatever number comes to your mind. 0.5 to 1 million. So based on that, the amount of the current you put on that thing is that you start with 3 million. So 3 million, if you're good at 3 million, you're about 2.5 to 4 millimeter away statistically away from the nerve root. But if you're good at 4 million, you're more than 5 millimeter statistically away from the nerve root. So for that reason, patient has to have 4 twitches. For that reason, if you reverse the anesthesiologist, it's always an eternal fight between the surgeon and anesthesiologist. If they paralyze the patient, and then you have to fight him afterwards, reverse it if they're stiffening, it's hyperexcitable, then your numbers are different. But we publish papers about that, so you don't have to guess. We will give it to you. But for all practical purpose, the amount of energy we store is 3 million, not because 3 million is what you need to put on the nerve root. 0.5 to 1 million. But it tells you what is statistically what distance you have to the nerve. Do you remember the part? If you are uncomfortable with that, be careful. You can stop and you see where you are going. But this allows you to cut another hour of surgery because you don't have to put the scope in. Like I know that Dr. Varun started with that, and I did a few dozen of that, but then I got that like Dr. Varun so comfortable that I quit using scope, and I only relied on neural monitoring. Now, for us surgeons, we are very visual people. Then it's hard for us to rely on numbers rather than we want to see things, we want to see the nerve. When I was doing my pilot training, there's something called visual flight training, meaning you see the landscape, you see the river, you see the sky, and you fly that way. But no jet flies with visual flight training. As a matter of fact, they teach you to ignore visual cues. They teach you to rely on instruments because that is safer. But we are all, I mean, I am trained old-fashioned. It was really hard for me to say, okay, I'm not going to see the nerve root, I'm just going to try to trust the numbers of the neuromonitoring machine and X-rays. But I can just tell you, the worst thing has happened to me was in surgeries that I didn't use double CRM and neuromonitoring. Okay, so meanwhile, at the 2000 kids, I can tell you, as instrument flight rule, IFR is safer than visual flight rule. Double CRM and neuromonitoring, in my opinion, has been safer than trying to find the nerve root and trusting that, when you're going there, you're not going to make it and so on. Does that answer your question?
Yes.
Okay.
I have a last question, sorry, sir.
Okay, well, no, I love question, but I'm going to apologize. When I put my life on it. I have done a lot of research. You are not going to ask me a new question, and if I give you a present, but I have a tendency to just start talking too much. Okay, so somebody has to ground me. Amanda, maybe you do that. You're good at it. Okay, please go ahead with your question.
You have told us about 2000 surgeries. So, you encountered any nerve injuries during that period, and how do you manage this?
So the question is, what is the rate of nerve injury? So as of last week before I came over, I did my 2027 surgery, and I have to answer your question in 2 ways: learning curve and after learning curve. Let's start with learning curve because that's what you are going to do when you start this. About 6 months before, and I give you the data. This is not a gut feeling. So, okay, who want to be a surgeon in this room? Please raise your hand if you plan to be a surgeon. You want to go to a surgical residence. So, something the surgeon learn is that when you ask them, like, how much is your blood loss, you say 100 cc. Just make it not 5 times more. Another thing is that when surgeon tells me, we learn that, I don't know why, in anesthesia asks us how long is it going to take, we just say 1 hour, and be sure it's going to take 2.5 hours. Okay, so quit using your gut feeling. Okay, you're a scientist, don't write it down. This is other people have been doing for a very long time. Okay, so this is the actual data, and I gathered about 72 parameters in the surgery, right in the surgery, and I have 42,000 follow-ups. I have every surgery is meticulously observed, the data is collected, and I'm going to give the data. In the learning curve, which based on what you bring to the table, I have actually a thing that shows you what that learning curve looks like. Let me show it to you because I think that really tells you this is my learning curve. So we made a science of how you thought and how you learn that. So let's talk about that. The learning curve, 6 months before I knew I'm going to start there, because that's how long it took me to set up the hospital and everything together to get the surgery done. I started gathering all my teams. And then after that, obviously I had a selection bias. Because my selection bias is that I'm not going to do in my learning curve complex cases. I'm going to do my easy cases. So I used all my tools before, and about 59 cases that the paper you saw, I stratified them. If you don't know what it is, you can just do complex cases in one group and easy cases in other group and say those easy group is better. But if you do the same surgery on the same complexity, you usually will fail. That's called stratification, that you're not statistically just fooling yourself. So we stratified the data, and what we found is that my rate of another thing. In my TIL patient, the next day after the surgery, they are in the bed, they are just want the pain to go away. All they talk about is the back pain, and that they just want to be able to turn from side to side. So they don't volunteer small things to you. So you have to make a habit of doing the actual exam. So that's what we did. We did the stratified data afterward, but we took all our killers, we examined myself, checked the patient, did all the exam, and you would be surprised how much you miss, because I thought my rate of nerve irritation with killer is much lower, was 12.4%. 12.4% of my patient after my killer had some various nerve irritation or damage. Most of that is temporary, but then it goes away. When I started doing my actually that the same study that Paula showed you, in my oldest group, that rate was 8.7%, so lower, actually lower, even in my learning curve. But those patients, they have more than complaint. They're ready to go home, but they notice the big toe is numb. So they complain more about it. Okay? Now, a small percentage of them will hit the ganglion, and they have this nasty neuropathic pain. That rate is much, much lower, probably about 3 to 4%, and has a very good prognosis. And then in the follow-up study where we published 300 patients, we looked at the 1-year data. In 1-year data, we saw that one patient, 303 patients, had permanent damage from the surgery itself. Now, obviously, if somebody had the thing before, and after that it didn't get better, maybe to have neuralgia or something else. But one patient had actually damage from the surgery itself, which made that rate 0.3%. You all know from all our data, 1-year result of killer nerve damage is reported somewhere between 1 and 3%. So now, after the learning curve, that rate comes dramatically down. It's never going to be 0. But my current rate of after, if you don't consider my learning curve, it's a little deceiving because my learning curve never stops. You see that line here. This is for all cases. But then, if you put the complex cases together, you see they have their own learning curve. If you put the grade 2 spontaneous diseases together, now I have 2,000 cases. I can't have enough data to analyze each group individually. So, but considering all of that, the rate of nerve irritation is about 6 to 8%, and the option of housing irritation paper. It has a fantastic prognosis, but still some people end up with neuritis, and that rate is probably 0.3 to 0.5%. But the problem is those neuritis are extremely nasty. Okay, you have to prepare the patient, and you ask me as well how I do treat, correct? So the first treatment is you talk to the patient. Okay? So whoever wants to ever treat the patient or talk to the patient or do the surgery on the patient who knows things are possible tells you, okay, doctor, you told me that. Okay, but the patient who is surprised by possible complication of your thing is going to blame you until the end of your life. And then may hasten your life, actually. So, so the first step is to talk to the patient. Then there are technical steps in the surgery that reduce them. The best treatment is avoidance. So, like, I don't freehand direct time trial and like navigate to the pedicle of the level below and walk it over. These are the risks for the nerve irritation. Number one is location. The highest one has 2.5 times more rate of nerve irritation than any other level. Number two is actually how many passes you do below the transverse process. More than 3 passes for one level and more than 7 total passes, it seems to be 1.8 times more risk of nerve irritation. And then the third one that the data is very clear, but it wasn't intuitive, is people who are neurontin has almost 2 times more rate of nerve irritation. And we found out it's not just neurontin later, as well some other medications that are prescribed for neuropathic pain, because this nerve is already at the verge of problem, and you just push it over. Okay? Now, what I was extremely surprised, the size of the cage was not a factor. And let me repeat that, because nobody would have told me that, I would not have believed that. The size of the cage is complication risk for other things like subsidation, but not for the rate of nerve irritation. Okay? So, now after the surgery, when it happens, again, you educate the patient that it's temporarily. You start physical therapy like very soon. In the surgery, I put steroid, and we talked about this. There might be a risk of infection, but I'm telling you, my risk of infection is 0.25. So if I need steroid, I accept that risk because dealing with the neuropathic pain is much more harder. I used to give a steroid injection, but now I don't even bother that. I put along the paraspinal muscle or where the nerve is, I stored a little bit of a cannula, which is a particulate matter. It doesn't go away. You put dexamethasone, it goes in and it goes out. Whereas particulate, steroid like cannula, it sticks around longer. Or after the surgery, you do metro dose pack for short, 2-3 days. If it doesn't go away, I start them on gabapentin and bring them to the proper dose. Okay, you remember? Some of them are already, but you can go higher. Now, obviously, gabapentin is not a medication that you give it as needed. You have to slowly go up, stay at least 900 or 600 or 900 for that to really start working. So patient has to be patient. That's what I tell my patient. There's a reason we call them patient. Be patient. Let this work for you. Then, if all of that doesn't work, I do a transforaminal nerve root injection. I literally go to the ganglion. But that's the last resort because this nerve is already irritated. And if you struggle with the thing and so on, you're going to hit it more and then all of a sudden things are even worse. But the injection, the steroid and local anesthetic, literally, some patients, they come and steroid and local anesthetic ball. They literally, while I'm watching them, the leg pain goes away. But the bad news is they'll come back. because the communication doesn't last for a steroid has longer lasting. Okay?
The size of the gate.
So one time,
The size of the gate.
when I was in TLIF, my size of my cages were between 7 and 10. Rarely, mostly 7, 8, 9. When I started doing this, I did not believe in indirect compression. As you know, you call for people who don't know, you call it to go and cut the bone, you call it direct compression. If you go and literally restore the hypothesis and lift up, called indirect compression. We published actually in 2019, 2018, 2019 a paper about that. I'm not calling it indirect compression. I think this is a root injustice to call it indirect compression because it's nothing indirect about that. Like most of you, I hope you don't have leg pain right now, right? You don't have leg pain. You don't have leg. You do not have leg pain because the height of the disc is preserved. The space that the nerve is passing out is not being. The nerve is not being pushed by anything, and that's what you are doing. You are restoring the height of the disc to preserve that space. So this is a physiologic decompression by anatomical restoration. That's the title of the paper we published. And it works beautifully. So, but I didn't believe in that. That's one of the things that I'm guilty as charged. You know, I saw the patient coming and I saw they are telling me, that's why I found the testimonial that I woke up and the leg pain was gone, but I still didn't believe in what I was doing. So I used cages 13, 14, 15. I really wanted to jack them. And my rate of subsidization was almost 9%. Not all of them proved to be relevant and stop, I never would, but certain percentage they were. When I trusted my own data, that's what I'm saying. I went from the case size of 13, 14, 15 to 10 to 12. I did not use any clinical result, but my rate of subsidization went down to 4, a little above 4, less than 1% clinically symptomatic. Does that answer your question?
So in the interest of time, we take the next talk now. We are ample time for all those questions.
That I'm really asking a question and just go on rants.
Thank you, sir. Please have a right
Excellent. Question and answer section. This is more or less answered so many questions we are thinking that everyone has it. So we have answered so many questions. Now, so I'm inpatient surgeon. I use my temper when an image identified person does not give me a good picture. That's one of the things that I do like it, because you get a lot of variations and every time you make it. That's why I think he's the best person that is using two CRs in a fixed positions. So that is one of the things that if you have two positions, two CRs, for the best, no problem. You can go ahead. The second thing is that we have a very poor setup. Poor setup in a way that every one of us does not have an access to neuromonitor. The third thing is, I'm also covered surgeon. The way in which Dr. Varun has done these things under local anesthesia, I cannot do it. Because I cannot tolerate even a hope from my patient. So these are the three things on which I based some change in my technique. Initially, I was doing a lot of discography. And in discography also, I used the same technique which I used it. I started using nerve blocks. The nerve blocks, I am also using the same technique. You see, the technique has not changed from what I had before. is just an extension of that, which is there, so there is nothing new. Every one of you are doing your own blocks, and the same technique I use for the entry point for this procedure. So I try to make it very simple, with less serum or less radiation, no need for pneumonia, and less radiation. These are the main knowledge at least which I have. With some anatomical knowledge, which always a surgeon should have. Which always a surgeon should have. So that is on which I have been this. So if you see that. So if you see this procedure, this is what everyone knows about is the triangle. And if you see the triangle, this is where the lung is. And you see this is hypotenuse. The farthest point is this. The farthest point is this. If you are farthest in the farthest point, there is very less chance of injuring the nerve. Right? So that's an anatomical knowledge that we have. In all these things, if you want to see this Kennedy's triangle, then the best way to see the Kennedy's triangle is this. This will give you the best way. That this is the pericle. This is where the nerve is. This is where the facet joint. This is where the SAT. This is where is your junction of the SAT to the trans. So if you have this picture in mind, which is very common, you know that we talking about this together. And so if you have this body dog, and if you put the needle there, then you are not at all going to damage the nerve. Okay. So this is very simple thing that I use in my technique, where I have only single serum, which is an oblique view, and with an oblique view, I have this corridor and on corridor, I target this area, and then the needle goes inside. So it is not AP, not lateral, it is only oblique view, only single view that I go inside. Now let us see. To reach that place is very, very important. How to reach that place? You should have first an AP view, squaring the end plates. That means you don't need any logos in your practice, nothing. You square the end plate, that is the first thing that you require. Then you have 20 to 30 degree oblique view, where you can see absolutely nicely the facet joint and the facet joint itself. So that is what the spotting dog that I use. After using the spotting dog, I start from 8 to 10 centimeters from midline. In fact, occasionally it's 10 centimeters. Otherwise, it is 8 centimeters that I go from the midline. So I draw a midline, I draw the disc level, then I go up to 10 centimeters or 8 centimeters from the midline. I direct the needle not in the disc space, because if you direct the needle in the disc space, the nerve can come in the way. So my direction of the needle is slightly inferior, touching the bone inferior of the inferior patellar, as was very nicely mentioned by Dr. Vasi. So my inferior touching the bone inferiorly. Then I walk on the bone. I walk on the bone to go to the junction of the acid-pain transfer process. That is what exactly I showed. Feel the dip. So once you are at the junction, you feel the dip. That is end of the bone. So feel the dip into the soft tissue at the junction, reaching the posterior annulus of the disc. Directly that valley will take you to the posterior annulus of the disc. And once you are in the posterior annulus of the disc, because you are going from inferior angle, you have to glide the needle inside the disc space and directly go up to the middle border of the pericle in oblique view and stop. Because you don't know, now you need to take your direction of the needle then inferior to superior and then get AP and lateral view. From my experience, you are always in center in AP and you are always center in lateral. So AP and lateral comes as the last part, just to check the needle placement. I'll just give you other direction and then lateral. This is how, this is this corridor. The needle enters, goes to this place. Then I walk on the bone, go up to this place. Once it is there, you can see the direction is from superior to inferior. I'll direct it a little bit from inferior to superior there, and then go inside. So then go inside up to this line, red line, which is the middle pedicle line. So once you go up to the middle pedicle line, check AP. You should be in the center in AP, and you should be center in that. And this is what exactly happens every time. So you don't need an AP lateral measurements or anything. This will give you exact AP lateral. So now coming to the clinical pictures, this is midline. This is 4 or 5 days. Measuring, you measure 8 to 10 centimeters. Take an oblique view. That's the oblique view. You can see the facet joint. You can see that this is the junction that you want. The needle which is directed there. Once it goes, you can see that there is direction from inferior to superior. Once it goes from inferior to superior, you are never endangering the inside the nerve root. So this is AP and this is lateral. So this is how it will go. And then you put in, of course, once the needle goes, you put in guide wire. Rest of the thing is just whatever way you want to do the other instrumentation. That's what you do. The most important point is how to use how to enter the display without damaging the nerve. So this is what my steps are to enter into the needle targeting or needle entry point. Initially, when I started, actually in 2021, I'm an olive guy. I think everyone knows that I do a lot of olives. So when I was given, I would write a chapter on complications of olive. So I went a lot of literature. And during that time, in 21, I came across all these papers of OLLIF and the other things. And then I thought that I think we should try this technique because that's much better technique. So at that time, I did not have anything. We did not have anything in the lab. But we all were doing extraforaminal discs. So this is the same approach as if you are doing an extraforaminal disc either through tubes or through an endoscope. So the technique we had, the only thing that you had to apply for the fusion states. So initially I started with 16 millimeter tubes so that I can I can see with the microscope inside what is happening. I can trim the facet joint a little bit if I want. And that's how I started with the tube.
So you need to press.
Oh, sorry. So then I started with the tube initially, and that's how 16 millimeter tube. I went inside and I could do the procedure. Once I had the guide wire in, I used all our routine instrumentation which are going like that's the routine disposal, whatever I had in MIS. The same instrumentation I was using. I did not have anything else with me. So that's how I prepared this, and I could put our normal instrumentation because I did not have the endo cage also at that time. So I just started putting the endo cage at that time. I never used endoscope for that. I was very happy with these cases initially. That's how I started. So graduating from that, I felt that it is better that because every time I put my instrumentation from facet joint to the disc, as Dr. Bas said, that many passes, more chances of irritation. So we have to decrease the passes between the facet joint and the disc space. And that at that time, I started doing with cannula with an endoscope. So that's the endoscope cannula. The needle placement is same. Then you put the cannula. That's around 8.5 mm cannula. And then after putting around 8.5 mm cannula, you have all the instrumentation which are there. The cannula goes inside the space. In the same way, these are cutters which will prepare the end plates. You have the articulated fluids which are there. So this is absolutely safe. And then I used an expandable cage. So I did not have anything to be done. Once my cannula is inside, everything is very, very safe. So nothing has to be done because everything is what Dr. Basi showed is everything is you can see that secured which are articulated. I just use the after clearing everything, I used an endoscope to check whether the end plates are related very well or not. That was for our satisfaction at the time. So that's how then you put the graph. This instrumentation are very costly. Again, my main aim was not to have this type of instrumentation because then it cannot go to the mass. So the third thing that I'm now doing is I'm using this whole thing is okay, but this is the case that I'm just doing all these steps for it. So it's a L4 file. This is, and you can see it's a great the B. That's an 8 centimeter incision that I take. I take usually a transverse incision so that I want to do sometimes the orthogonal maneuver. So to make it more horizontal rather than vertical. Then that's the needle. The needle goes the same direction. Then you check the AP. The AP is in the center. You take lateral now. The lateral also is in the center. That's how it goes inside. Remove it. Put the guide wire inside. After that, I usually use the what I can say is maximum reverse or these levers, which will increase or may do a little bit of running faster at that time. But then I'm using these half sleeves now. With this half sleeve, you see I'm putting the half sleeve inside of this space. That will protect my exiting nerve. Once this half sleeve goes inside, this is protecting my exiting nerve. And because it is open on one side, I can use all my routine instruments. I don't need any specialized instruments now. That I was using with my cage, my tubes. So it's a half tube. So that's our routine T-diff scrapers, which are there. That's our routine disc forceps. Then clear all the thing, all the disc tissue. That's my routine garrison, which can go if you want, or routines periods which are going inside. And that's the pedal shaver. If this goes inside, it will give you exactly the height of the cage, what size you want to put. So it goes inside and you rotate it. Once you rotate it, you check under CR. You can see that this is the size of the cage that I need to use. And then the rest of the things are all putting our routine funnel for training. And then this last point I just wanted to show you is the position of the cage. The cage goes, this was an endo cage, but I am using a routine cage cage also. You don't want to use because you have a sleeve which is protecting the exceeding nerve root. So any type of cage you can use with this sleeve. And you can see that after I'm coming inside, you can see my position of the hand. I'm doing an orthogonal maneuver, which goes down. When you check under C-arm, that it is more horizontalized rather than going from the same. That's how you check it. Then you remove the obstacle, then you remove the. That's the cage position. Then check the how it is very well fit of the cage, and then remove it. Then have a final check. That's the position of the cage. It's quite, you have to have at least 5 meters of space from the posterior margin of your body. So that's it from my. If you use these three, there are certain advantages and disadvantages of all these three procedures. But if you use the half cannula, inner is totally protected. Your ever-ended preparation can be confirmed. All the routine instruments can be used, and no special case design is required. That's how I do my this procedure. Thank you. Thank you.
To speak on this most talked about the review, that is whether under
Great job, great presentation, thank you.
Everybody to the review. And it's we have to have such highly experienced industry surgeons for a lot of them, and we might teacher as well. As well, but the answer is still running from well. I was talking about how I do this procedure under local anesthesia, and all of us who are from the endoscopy background are not stranger to how to do these procedures at the endoscopy. So back pain is the leading cause of occupational disability, as we all know, and second most common symptom related reason for seeing of the patient. These are the routine cases which we see in our practice. This is another case of diseases, another case of diseases you can see right there. So how to do it under local anesthesia. This is a 40-year-old female with pain in the back with radiations to both over the lips, and SLR on the right side being 20 degrees. And you can see the diseases and the stenosis there. The MRI picture. So this is a dual scion setup. You can see the one scion comes over the top and it is in the middle of the. So this is for the lateral view and this is for the AP view, and this is where the surgeon stands. This is the back table for easy positioning of the instruments. And if I can fit in this way, I guess everybody of you can as well. So and I do it at the single scion as well, and we're talking about that also. So this is how we mark the risk phase, the diameter is inserted. You can see that the patient is done away and under local anesthesia. We have a big drill and big curettes all go through this sleeve working channel, which acts as a sleeve in itself to protect the nerve root. And you can see the patient is away. Put the cage after putting the primer, and this will be taking out the cardiac arrest bone graft again under local anesthesia. Since we will be discussing all these in later, it's just I'm going through this very quickly. And even the screw now are placed in the local. So I infiltrate the entry points of the screw right up to the periosteum with a mixture of local anesthetic, which is 50% ibuprofen and 50-50 5 ml of ibuprofen, 5 ml of ibuprofen. For quicker onset, I use ibuprofen, and for longer duration of surgery, ibuprofen. So by the time the effect comes, you start the same. The regular way of putting the shading, nobody is a stranger to that. In the interest of time, I just did this. So this is how the final construct looks like. This is the rapid view, you can see this when we view, and the AP view. These are the scars of the surgery. Transverse incidents sometimes I take for the screws because they are more prosthetic eventually. For the rod incidents, you can see small scars depending on the system which we use. For the cage and for the bone graft. This is the immediate post-op, and by you can mobilize the patient as soon as they are comfortable. So can you do adequate risk preparation? This is a question which everybody asks. You can see the amount of risk preparation that has been done. So, despite easy to do that, but you will crush the executive loop. This is another question everybody keeps on asking. So I made this a small video on the model, and you see the design of the cage is very important for this. So this is 13 mm cage. This is the model. So even if I use a 16 mm, it doesn't matter. But you see, as the cage glides it, the tapered nose just pushes the editing loop as it enters. So the design of the cage is, really what makes the kind of service possible under local anesthesia. So enough of the fancy stuff, but will this fuse eventually? This is another question. So another 55-year-old male, back pain. This is the identified as well. You can see here. So immediate post-op X-ray, a 1-year follow-up, a 2-year follow-up. You can see the bone well inside, outside, all around. Just fuse very nice and well. So is it good enough for 1 level only? The 48-year-old female, this is at 3-4, reduce this height at 4-5. It's a 2-level cage, another 1 level local anesthesia. The 45-year-old male, back pain, bilateral radiculopathy. This is at 3-4, reduce this height by 4-5 as well. This is a 3-level cage, and everybody would agree that this all 3 levels require some sort of being addressed to. And this is the MRI, and all 3 levels, you can see the stenosis there. And this is a 3-level case, again done in the local anesthesia as well. This is the post-op MRI. You can see how well with the indirect decompression the canal has put down. So the cases which are suitable for indirect decompression are, the best cases which we can do with this. This is a 70-year-old male, LTF regions pieces. Lumbar canal stenosis, patient care complex of low back pain, type 2 diabetes mellitus, and he was already had the surgery done elsewhere 5 years back. With an adjacent segment problem, he was developing. So, there was a very high risk for general anesthesia as well, with the uncontrolled diabetes, etc. So, once we had controlled the diabetes and all, so this is what I did: end-to-end with transcranial lumbar interbody fusion, and just bypass this entire segment. Just fix this. So we did this in the local, again under local anesthesia. This is the post-operative bone you can see. This is the scar of the previous surgery, and these are the scars which we gave to the patient again under the local anesthesia. So around 59-year-old male, progressive low backache since 2 years, neurology intact, but SR on the right is 45. So he had degenerative disc disease 3, 4, 4, 5, and lumbar canal stenosis. So 2 level, both are requiring fusion. So in this case, you can see the pre-op MRI, and this is how we address. So we mark the level, the ATU. So this is a single CR case, and then mark it in the lateral view. These lines are marked like we do engineering for endoscopy of the patient's back. Then for other level, the midline is marked, and then the guide wire inserted. Never cross this median pedicle line till you are sure of the lateral view, because that is where you will see the traversing of those lines, and then the guide wire will be just inside the vertical border. This is followed by the dilator, then the working channel, and then first comes the big drill to make a path, and the other instruments which you will see on the second screen outside as well. And you can just do a quick dissecting, and then finally put the bone cage at the ground. So for the lower level, again we mark, but there was a high iliac crest, as everybody can see there. So we did a trans-iliac approach. First is the first Jamshedi to make a small hole in the iliac crest, right in line with the disc, like the routine thing, and then the guide wire to the medial pedicle line. And once you just cross the posterior vertical border, followed by the dilator, the release is not there, but then the maximum reamers are used serially again to expand the window. Then finally the cage. So in a trans-iliac approach, you can usually do an alpha test. And then finally, the guide wires for the screws. to the regular machining today and then station under local anesthesia. These are the intraoperative images. Final post-operative radiograph. This is the post-operative MRI. You can notice very compressions there. You can see this one every other before and this is the post-operative. So before again, pre-operative and post-operative. These are the post-operative scars and patient mobilized. These are the results of 66 patients which we did. The rest of time I'll just go into it. And this is the anesthesia protocol which I follow. This is local infiltration of 5 ml lidocaine with ATR plus 10 ml sensorinane and 5 ml of NS. This is the mixture which I use at the base level. So this we are mainly using it in the transdermal copy as well. Then I use IV dextrin infusion for sedation, dexmedetomidine, 1 microgram per kg for 15 minutes loading, followed by 0.2 to 0.7. The advantage is it decreases the heart rate of the people. Because patients are anxious, their heart rate is more, and it is titrated than automatic syringe pump. Then IV fentanyl 50 mics, then needed when the really painful parts of the procedure are there when we are putting a dilator through the annulus and sometimes using the screw as well. Medas only I use, this is a very low dose medas for angiolysis, not in the sedative dose, and nitroglycerin infusion if the desired use is not maintained by excess. And initially, few cases I used to do on the epidural line, but now I don't do it anymore. But this was the concentration when I was doing it under epidural. 4 ml of 0.5% local, 5.6 ml NS, 0.4 ml fentanyl. This 10 ml mixture we used to infiltrate in the epidural space. The take-home message: the realm of percutaneous techniques as handling include fusions and fixations. Careful patient selection is mandatory. Indirect decompression, if it can work from the front, like the Olive procedure, the approach slowly work from the back as well. And you always have the option to use an endoscope if you require more decompression. So if for the patients which require direct decompression, then I use the endoscope, or maybe you can use the tube as well to make the minor space, which after restoration of the anatomy, either cage and the screw placement makes the decompression job much easier. So all of us who are doing endoscopic and decompression, all of us have more than 5 or 10 years of experience. And it started that we doing the decompression is also quite a challenging and time-consuming task. And in cases you require fusion as well, I do this first so that my decompression time and efficiency improves. Thanks a lot for your patient hearing. I invite everyone to join me. Thank you very much. We'll take a short break for coffee and in another 5-6 minutes we can get back in the interest of time because we have a dinner plan for everybody and we don't want to wait for that.